Hello, everyone. My name is Carissa Little, and I am one of the account managers here at USDTL. Thank you all for joining us today for ToxTime. And if you are new, we welcome you. Today's presentation topic is a review of specimen types and recent developments of newborn toxicology. And presenting today, we have Dr. Joseph Jones, Chief Operating Officer here at USDTL. We also have Aaron Murray, one of the business development managers, who will be the moderator for today's event. Now, I'm so excited to get started with this great presentation, so I'll go ahead and pass it off to Dr. Joseph Jones. Thank you, everyone, and enjoy the event.
Thank you, Carissa, and welcome everyone to this edition of ToxTime. I'm Joseph Jones, Chief Operating Officer. So let's get started. Today, we'd like to talk about newborn toxicology from the perspective of taking a little walk down history lane, discussing the different specimen types that have been popular over the years. And then at the end, we will discuss two recent developments in newborn toxicology that you may find of interest. Over the years, I've had the opportunity to work with and make acquaintances with several respected people in the field of newborn toxicology. One of these is Dr. Loretta Finnegan, and I had the opportunity to have a conversation with her about how did you execute testing, say back in the 70s when you first came into the field. And she told me there was no routine testing, and that as the heroin epidemic back in the 70s progressed, there were attempts made to come up with consistent strategies, but they were not part of any guidelines. She also told me that when they did test, it was urine and it was absent confirmation testing. So we all know how important confirmation testing is in this environment. There's a lot of liability and potential litigation involved with specimen results that are not confirmed by an appropriately specific methodology. Further conversations with Doug Lewis, who was from a lab perspective back in the 70s. Doug told me earlier this year, he said, you know, back then we were in the technological dark ages. Mass spectrometry was only for PhDs. And so these samples would come to you for mass spectrometry, and they'd go into a little black hole, and a couple of weeks later, this PhD type would come out with some answer. And you didn't question these people because no one understood the operation of mass spectrometry 50 years ago. Doug said that in his experience back then, only very high profile forensic cases utilized mass spectrometry for the identification of drugs in a case. So along came the 1980s, and with it came a lot of advancement in two very important technologies in this field. The first was immunoassay, and the second was mass spectrometry, specifically gas chromatography, mass spectrometry or GCMS. The front runner of the Federal Drug-Free Workplace Act was the need to have robust, high throughput platforms in order to do urine testing for the military and for federal safety sensitive type positions. And once laboratories established these types of technologies and strategies and platforms in their laboratories, these strategies became available to hospitals. And what they found was that these strategies were very practical and cost effective. But the sensitivity at the time was appropriate for adult urine specimens. Alternative specimens was not really a consideration of discussion back then. And the sensitivity for doing newborn specimens or like alternative specimens like hair, fingernail, eucord, placenta, amniotic fluid, the sensitivity was just not there with that equipment, but it worked great for urine. In '87, the Federal Drug-Free Workplace Act was signed into legislation. Millions of drug tests were executed routinely throughout this country. So this was an easy concept to leap to. Well, why don't we test the mothers? We'll test their urine on intake. Many organizations did set up this type of profile. When mom would come into the hospital, they would collect a clinical urine specimen, and one of the tests they would execute was a drug test. And they started using the results of that drug test to report back to the state for intervention or for whatever reasons that DHS needed. In the 90s, this strategy came under legal scrutiny. Specifically in South Carolina, petitioners challenged that the validity of the policy under various theories, including the claim that warrantless and non-consensual drug tests conducted for criminal investigatory purposes were unconstitutional searches. And so what was happening is that these clinical urine specimens on intake were ultimately being used to report back to the state to start cases with the local child protection services. So the courts, all the way up to the Supreme Court, noted that these urine tests conducted by those staff members were indisputably searches within the meaning of the Fourth Amendment, meaning that they had abridged those rights, and that they agreed with the court that this policy cannot be sustained. So at this point, people are starting to think, well, how are we going to do drug testing? We need testing. There's no doubt that we need testing. And even the justices in the Supreme Court decision that I was reading through to prepare for this ToxTime, they talk about that they fully understand the need of the testing in this environment. So we've established the reason why we use newborn specimens as opposed to maternal specimens. Now it's time for a poll question. What specimen types are you using at your hospital for newborn toxicology? If you don't mind answering this quick question for us, we'd be greatly appreciative, and then we'll move forward. So considering the equipment and the strategies and the technologies available at the time, the next obvious specimen type to stay within the Fourth Amendment would be using the newborn urine. There's a number of advantages. Urine is by far the most understood drug testing specimen type. We have conducted urine testing for decades in a high throughput scenario. It can be performed right there at the hospital. You don't have to send it off to another lab and wait a couple of days to get your result back. And by and large, urine testing is very inexpensive when compared to other types of testing. Now, the drawbacks to using newborn urine is the collection is awkward. Anyone that has bagged a baby to collect a urine specimen, it's not the easiest thing to do. It's not the best way to go. You have a very narrow window of detection, 1 to 2 days. This is a big deal in this environment. You must catch the first void because the baby urine is dilute. And if you miss that first void, you're just kind of looking at what's in the milk the baby's drinking at the moment. The volume is low, and because of that, there are many specimens that are reported out, quantity not sufficient for testing. You just run out of sample. So to kind of point out some of these limitations, there was a urine study back in the early 90s, and the purpose of the study was comparing universal collection for drug testing versus targeted collection. And they were testing newborn urine. And in this study, they had 1,150 live births. But 137 of these babies, they were unable to get a urine specimen for a number of different reasons. It was either transferred to another area of the hospital, or the baby left the hospital, or the specimen was contaminated, and then others, there was just simply no reason given. Additionally, there was no mass spectrometry performed on these specimens. As the authors say, they just didn't have enough specimen. So these are immunoassay only. I pulled this quote from their paper to include here today. and they said that a positive result is indicative of drug use only during the few days preceding delivery. A negative result does not rule out drug use earlier in the pregnancy. So this is a big limitation with regard to testing newborn urine. As technology progressed during the 90s, using newborn hair became feasible. And so the pros of using newborn hair is that you've got a long detection window, about 2 months, and it's not invasive. You don't have to bag the baby to collect the hair. You don't have to draw blood. You just cut the hair. The problems is that it's not a universal specimen type. 1 in 4 babies is born without hair, and even more than that, there's just not enough. Even though they do have hair, it's not enough. There's minimal literature on newborn hair. There's a few papers out there, but not like you see with those other specimen types. And in hair testing, especially in newborns, it's very technically demanding. In the same time frame, the use of meconium became useful. Same technologies and platforms that made hair possible were also usable for meconium. Meconium is the first little poo that the baby takes, and it's been sitting there for weeks before it's passed, before delivery. And the advantage with meconium, and it's a huge advantage, is that it looks for the whole trimester. So up to the last 20 weeks, you may see in the meconium. So it's an incredibly long detection window that we see with meconium. Again, it's non-invasive, and there's elevated concentrations. So the equipment that you need is you don't have to have very expensive equipment to do this type of testing. And by now, we've got decades of literature on meconium. There's a lot of papers out there with newborn drug testing using meconium. Now, the drawbacks is, again, it's not completely universal, much better than urine, but it's not completely universal. It can be passed in utero. It can be not captured for whatever reason. Small volume for like the sickest little babies. It requires multiple collections. So this becomes an issue with chain of custody and specimen identification integrity. It may require many days to collect. Sometimes you're lucky and you get the sample out within 24 hours, but some of the little babies, it can take 3, 4, even 7 days in some cases. It is technically demanding, not on the equipment, but just on the extraction and the specimen handling and the specimen prep. Working with meconium is just physically difficult. And another big disadvantage is that it is heterogeneous. In other words, all the passages of the meconium do not have an equal distribution of the drugs. So the best specimen for meconium is the entire passage of meconium. So we have 3 issues there. Are we sure that we got the first passage? Number 2, we aren't really sure when the meconium ends and the milk stool starts transitioning in. And so these are 2 big issues with collecting meconium. I've often referred to this study that compared the diagnostic yield using meconium versus urine. And so this was a large study, retrospective analysis. It was over 4 years. The specimens were tested at a state academic hospital. 2,851 tests were ordered, and of them you had 2,497 meconium and 1,773 urine. And as we would predict, the collection success was in favor of meconium by 88% to 75%. But the detection of at least one drug, we had a 23.3% positivity rate with meconium, and they only found 4% of the urines to have at least one drug. If you narrow that scope down just a little bit to only non-medical drug use, the 23% was at 9.2%, which is pretty good, but the urine was only 0.7. So this paper points out really dramatically why meconium has bypassed urine as a choice for newborn toxicology over the years. It's just much better. Here's another study that I have referred to often over the years. This was published by a group out of Toronto, Canada, back in 2003, when they compared the sensitivity of meconium testing and hair testing. And so between 1999 and 2001, they found 185 matched pairs in cases where there was reasonable suspicion, and they calculated the sensitivity of meconium testing and hair testing. For cocaine, a big difference, 96% to 84%, and the metabolite benzoylecgonine, 95% compared to 78%. Opiates was about the same with 87% and 87% for both meconium and hair, but marijuana was by far more sensitive with the meconium test at 98% versus 71% for hair. This is a slide that I put together several years ago to demonstrate the non-universality of using meconium. So these are 5 studies, important studies in our field, and these are studies where they were intent on collecting meconium to execute a large National Institute of Health funded grant. And in each of these cases, there was a significant number of the meconium that were not available for testing. And so this test in 1999, we had 61 out of 218 where they enrolled the moms, but they didn't get the meconium. The next case was Leicester with the IDEAL study in 2001, where they had 8,500 moms enrolled, but 3,200, they didn't get the meconium on them. That's a big hit if you're trying to conduct a research project. Chris DeRoff in 2003, he missed 20% of his. 2005, there was a study where they missed 9.8%. And the most recent one that at least I reviewed was Teresa Gray when she missed 14 out of 102. So clearly, these researchers were motivated to capture these samples to execute their grant research, but these meconiums just were not available for a number of reasons. So research is not the only environment where meconium specimen collection is missed. Our team was visiting a group at McCady Hospital out in Salt Lake City, Utah, about 15 years ago. And the nurse manager approached my friend and colleague, Bob Demery, and said, "Bob, there are too many rejections due to insufficient volume. Why can't we use a specimen that is plentiful to begin with?" And Bob said, "Well, what have you got in mind?" And she said, "Umbilical cord. There's a ton of it, and we just throw it away." That's an interesting question. So we started looking into considering umbilical cord tissue as a newborn specimen type. The pros are it's truly universal. And as the nurse manager mentioned, there's plenty of specimen. Quantity not sufficients are rare. A little feedback at our laboratory, over 15 years, we've had like 4 cases. It's a single step collection, which means that there's less opportunity for specimen identification integrity issues. The drugs are distributed homogeneously all the way down the length of the umbilical cord. The integrity of the specimen ID is much improved. One baby, one mother, one collector, 2 cuts, in the cup it goes. You put the seal on it. There's no chance of that being mixed up with another specimen. We have a long apparent detection window. When we started developing this test, we compared them with matched pairs of meconium to do our best to replicate that positivity rate. Non-invasive, you don't have to poke a vein. You don't have to bag the baby. It's a real simple collection. And while the baby is passing meconium, the U-cord is already on the way to the laboratory. So it's available immediately. A couple of cons. It's very technically demanding. The concentrations are very low. And so some first attempts at different laboratories working on this, the cutoffs are too high. You just have to go back and keep ratcheting it down until you get the cutoff in the right place. And there's a growing body of literature. So it started from nothing, obviously, but over the past 10 to 15 years, we do have a good body of of literature to assist us with the interpretation of these results. In regard to the very beginning of our discussion today about whose specimen are we testing, this question came up at the very beginning when we started working on umbilical cord. And that's like, who does the cord belong to? Is it the babies or is it the mamas? And so if you refer to any of your graduate level anatomy books, you'll find the same information, such as Gray's Anatomy. The U-cord belongs to the baby. It's a stalk that develops from the embryo, starts forming in the first 5 weeks. So it starts from the baby and grows out and attaches. And so this is genetic material from the newborn. So that satisfies the Fourth Amendment requirement in that the baby is the patient here. And so if there's a suspicion of drug exposure to the baby, you're treating the baby, not the mom. And so ordering a forensic test on the baby is well within the Fourth Amendment constitutional rights. And now for what I consider like the fun part of these talks times is let's look at some literature and some real data from the laboratory. So here's a paper that was published last year about gabapentin and opioid co-exposure. So gabapentin was once thought to have a low abuse potential. Abuse is increasing, however, among substance use disorder patients because it potentiates euphoric effects. And what we have found in newborn toxicology is that neonatal abstinence syndrome is prolonged and can be more severe in the presence of gabapentin exposure. The Utah group put together a large study, retrospective chart review, their national reference laboratory, over 25,000 umbilical cord results. And their demographic was high risk just because if you look at the gabapentin positivity rate, that was at 2%. And so that's not a general population type number. So this is a high risk population that they're testing there. But it was 2% positivity rate for gabapentin nonetheless. And only 30% of those were gabapentin only. 70% of the gabapentin positives, there was also another drug on board. So this is interesting. So looking specifically at the co-exposures, they reported that 32% of the gabapentin positives also had the metabolite of buprenorphine, norbuprenorphine on board. They reported that 15% had amphetamine on board, 13% had buprenorphine itself on board, 12% had methamphetamine on board, and 11% had morphine on board. So what does this mean? The main takeaway from this study was the high co-positivity rate between gabapentin and buprenorphine. And so what the author stated, and I drew this quote from that text, was that one possible explanation for the high gabapentin and buprenorphine co-medication rate observed in this study is that pregnant women undergoing opioid substitution therapy with buprenorphine might be using gabapentin to enhance the euphoric feeling from buprenorphine and or minimize the withdrawal symptoms. And so this is occurring in a backdrop where there's not a lot of literature on the long-term effects of these co-exposures on the newborn. How does it affect the NAS and how does it affect the long-term health of the child? So if you're not looking for it, you're not going to find it. And so it's important that gabapentin be part of your testing strategy. Now let's turn our attention to some data here from USDTL. One of the significant trends that we have been seeing over the past couple of years is this rapid increase in the positivity of fentanyl in the umbilical cord. As we can see over the past couple of years, positivity rates have almost doubled. Taking a little deeper dive into this positivity rate, we wanted to see was there a difference between pre-COVID and during COVID. And so we separated those out, and you can see here that the positivity rate has doubled during that timeline, and that difference is significant. Further unpacking some of this fentanyl umbilical cord data, compared to the 30% gabapentin only reported by the Utah lab, fentanyl was 7% fentanyl only. So that means that 93% of all the fentanyl positives had another drug on board, specifically morphine at 57%, methamp at 40%, amphetamine at 33%, carboxy-THC at 26%, and benzoylecgonine at 24%. So all of these fentanyl positives had these other illicit drugs on board at the time. And so the morphine being at 57% is not too surprising in that we've heard for years about the heroin supply being laced with fentanyl, and which is a big issue with heroin overdose. The fentanyl's in there, and you don't know it, you can get in trouble quick. But interestingly, the stimulants, methamphetamine and cocaine, are also contaminated with fentanyl, not contaminated, but laced with fentanyl. And one reason is that if you are an abuser of these stimulants, it will take the edge off so you don't have the jitters. You can still get high from the drug without the jitters, so you can function kind of under the cover, and nobody will notice you as readily. And then marijuana, usually, drug users are at high risk of using marijuana itself. I think my main conclusion from this is that a good portion of the drug supply in this country is laced with fentanyl. So buyer beware, it can be very dangerous. Now that we're near the end of our presentation today, we have another poll question for you. In response to requests from the field, we recently lowered our fentanyl cutoffs. And would you like to learn more about the lower fentanyl cutoffs and how they can help prevent missed positives? If you would like to answer this poll question, we'd appreciate your response. So in conclusion, over time, newborn toxicology testing strategies have evolved, and they've been responding to improvements in instrumentation, responding to the legal environment, research and innovation, responding to challenges specific to newborn toxicology, and last but not least, the notion that the confirmation of presumptive positives is very, very important. We've also talked about gabapentin and co-exposure with other drugs and the issues that brings. We've talked about the increase in the prevalence of fentanyl and the dangers that's involved there. So I'd like to point this out, is that if you're not looking for it, you can't find it. So I would urge you that at this time, take an opportunity to take a look at your facility's protocols to see if it includes looking for some of these newer drugs that are trending in our country. So with that, I thank you for your attention.
Subscribe to our channel to see more videos like this.